by the people, for the people, the gathering to get health care now. Chapter 14. Insurers and their financial goals. If a practice has 100 or more patients from an insurance company, then that insurer will expect to spend less than 80% of the premium for hospital and professional services. If more is spent, the insurer will consider that practice a loss and will decide that either the patient population is too sick or the physician is the cause of the overuse of services. If a problem is not solved in a few months, the insurer sometimes terminates the agreement with the practice. The physician is afforded some protection from this action by the IPA. But if the situation is the same with most of the IPA physician members, then the plan will terminate the IPA. The consequence of termination of a physician is the patient might not move to another new provider and will drop the plan. Or if the problem is the physician, then moving the patients to a new physician that has a, quote, good bottom line will accomplish even more for a profit-driven insurer. IPAs that are completely independent from health plans and from hospitals stand the best chance of avoiding cancellations. A reformed healthcare system must eliminate this insurance company practice and perhaps can do this by judging the physician within his or her team based on the patient outcomes and not just the bottom line. Sometimes patient populations are unhealthy and the premium does not match the real cost. There's currently enough fat in the non-professional portions of the Medicare Advantage health plans and Medicare to offset most of the possible losses until real solutions are worked out. Under the new healthcare law, PPACA, the plans must pay 80 to 85% for medical and hospital services or rebate to the patients. This means that the IPA should be able to increase provider reimbursement and performance bonuses. Having made a roster of medical teams, IPA organizers could think that the IPA is in good shape. However, they will not know the true condition until sick patients show up in the utilization reports. It's only then that the physician and nurse reviewers discover who did or did not do what was needed for the patients. The organizers may think they have picked the right hospitalist, but the hospital system may have put patients into the care of someone not on the IPA team. Even if the IPA team has extensive experience controlling hospital admissions, the team must develop enough activity to correct the admission errors that are likely. Teams from the past may do their work without interference from the hospital's case managers, who are often motivated to maximize the hospital's revenue. The IPA's hospitalist should see the patient to determine what is wrong before an admission. They absolutely must not admit a patient to the hospital unless there's no other alternative because of the risk of disease and injury in any hospital setting. IPA hospitalists must have good relationships with the ER doctors. They must have their consultants on the spot within hours, especially for cardiology, neurology, gastroenterology, and orthopedics. The hospitalist should not admit patients to ICU who will not survive, such preemptive transfer places unnecessary financial burden on the hospital when hospice is the viable alternative. They should continue to observe the patients to improve and update diagnosis. When they do admit a patient, they should keep him or her until the problems are resolved and hospitalization is no longer required. The hospitalist should prefer a skilled nursing facility, in most cases, instead of long-term acute care facility. The hospitalist must plan the discharge of the patients and get them back to their primary care physician as soon as possible. Team physicians cannot have financial interest in a facility or a tool company they may use, especially the hospital, the SNF, or the LTAC. The key to the team having good outcomes is attention to detail and a profound respect for team members who are helping the patient. The work is about mitigation of suffering in others. It's not a performance seeking an award. Some IPA teams have shown an extraordinary sense of responsibility in the care of their patients. This is a primary characteristic of people who mean to relieve suffering. Remember that the word patient means a person who suffers. Outside motivations in caring for patients like money and fame are bad character traits. The physicians who are all about the money or all about recognition should not be on any teams. They destroy the team, and everyone on the team knows it as soon as you try to include them. An insight into the right understanding of the practice of medicine has been written by Dr. Nasser Gaim, MD, who said that following about himself and his peers, we doctors are not gods, nor should we wish to be. The concept of medical godhead reflects a mistaken notion of medicine, in my view. I call it Galenic because it stems from the medical theory of Galen, which has seeped into our profession, our culture, after 2 millenniums of wide acceptance. This is a view that nature causes disease, and that the doctor fights nature to cure the disease. The doctor provides the cure. Only a step is left to Godhead. The other view, long lost, but deeply correct, I think, is the Hippocratic view of medicine. The idea here is that nature heals disease as well as causes it, and the role of the doctor is to help nature in the healing process. The doctor is not the central hero, but the handmaiden to nature. And this does not mean that cure does not occur, but it occurs less than we think. And nature deserves the credit, not any human being. There's no room for a doctor's God, and our purposes are more humble, to cure sometimes, to heal often, and to console always. Medicine's a complex affair. We frequently do not do justice to what our patients suffer and what they need. Pretending to know more than we do only makes matters worse. But being honest about what we do not know is not a sign of weakness. The IPA physician can find physicians that understand the true nature of their practice, and they can become a team. It is to serve the needs of patients and to operate within the budget dictated by government, businesses, and patient associations.